Good morning. This is a great honor and pleasure to be here in Hong Kong for this conference and talk about my work on aplastic anemia and especially its relationship to clonal evolution to MDS and AML. I'm currently at the University of Sao Paolo in Sao Paulo, Brazil, but a great deal of the work I'm going to present today to you was conducted at the U.S. National Institutes of Health, the NIH, at the hematology branch. So before I get to the clinic, I would just like to go to the basics of biology and to the telomeres that are the central molecular pathway in this relationship between marrow failure and clonal evolution. So the telomeres are the tips of our chromosomes. And since our chromosomes became linear instead of a circular, you have a problem imposed by nature that the ends of the chromosomes should not be seen by the DNA repair machinery as a broken DNA. So the cell came up with this structure that is the telomere, which includes a repetitive sequence of hundreds to thousands of TTA-GGG repeats at the ends of the chromosomes. And it makes a special structure at the tips of the chromosomes, making a lariat or a T-loop here. And this T-loop hides the blunt ends of the chromosomes from the DNA repair machinery. This is somehow done by this repetitive sequence of TTA-GGG, but also by a collection of proteins that are collectively called sheltering, that hides the ends of the telomeres from the DNA repair machinery. So as opposed to breaking the DNA here in the middle of the chromosome, which could be recognized by the DNA repair machinery as a broken DNA, for instance, when you have radiation, and the DNA repair machinery tries to mend this DNA back together, it doesn't happen to the ends of the chromosomes or the telomeres. The major problem of having telomeres or linear chromosomes is that the DNA polymerase is not able to fully duplicate the ends of the linear DNA after every cell division. So no matter what method you use to measure telomeres, whether you use fluorescence in situ hybridization, in which you can see here that we can physically localize the telomeres that are lighting up here at the ends of the metaphase chromosomes, or a combination between flow cytometry and FISH, in which this fluorescence is quantified by flow cytometry, or the gold standard southern blot, in which we can see a smear of the telomeres, or quantitative PCR techniques. No matter what method we use, we're going to see that in our body, the telomeres of the cells get shorter as we age. And this is an example of the telomere length in peripheral blood leukocytes. Here we have the age from 0 to 100 years in the telomere length, and we can see that in the cord blood, the telomeres are longer, and they get shorter in the first 2 decades of life. Then they sort of plateau, but later, after age 60, they start getting shorter again. To counter this telomere shortening, the cells that divide rapidly, for instance, the hematopoietic stem cells, but also peripheral blood lymphocytes, they express a special enzyme that is a reverse transcriptase. That's the only reverse transcriptase that we actually have in human cells that elongates the telomeres. It uses an RNA component, an RNA molecule that is called TERT, and this reverse transcriptase called TERT or telomerase elongates the 3' end of the telomeres in these cells that are rapidly dividing. For instance, the hematopoietic stem cells in the bone marrow. There are also other proteins such as the scarin that binds to this complex and stabilizes the complex. So the first association between telomere shortening and marrow failure was done by Sarabola at the St. George's Hospital in London when they found a progressive telomere shortening in the leukocytes of patients with aplastic anemia. At that time, it was not very clear whether the telomere shortening was the cause of aplastic anemia was merely a consequence of excessive bone marrow stress or division of the hematopoietic cells in response to aggression to the bone marrow. And later, our group at the NIH with Peter Lansdorp in Vancouver found that the cells were mostly affected by telomere loss were the neutrophils in peripheral blood. There is a syndrome that is a rare syndrome. I don't know what is the incidence in Asia, but it's called this Kurtosis Congenita. That is the second most common cause of congenital aplastic anemia. And probably, since we discover more about the genetics of this disease, maybe it's even more common than Fanconi anemia, that is characterized by neodystrophy, this reticular hyperpigmentation of the skin and leukoplakia in the tongue or of the buccal mucosa. And this is caused by mutations in the X chromosome in the gene called DKC1 that codes discarin. That is that protein that gives stabilization to the telomerase complex. This was discovered by Androgens in London, the Hammersmith Hospital, about 10 years ago. But we didn't know what this protein discarin did at the time. It was later that Kathy Collins found that discarin was part of the telomerase complex. And then it was more clear that the telomere shortening that we saw in aplastic anemia patients could not be a consequence of the marrow stress or the marrow injury, but rather a causative event in aplastic anemia. And later we found in patients with apparently acquired aplastic anemia that about 5 to 10% of these patients do have constitutional mutations in the telomerase gene, the gene that encodes for the reverse transcriptase. And what is interesting, these patients with aplastic anemia, that part of them with mutations is part of them have not severe aplastic anemia, but a very long time history of moderate aplastic anemia. And also they have a very clear story of myelodysplasia or acute myeloid leukemia. When we measure the telomere lengths in the cells, peripheral blood leukocytes of the patients with these mutations, in yellow here we can see the healthy controls. There are about 400 healthy controls from 0 to 100 years. But when we can see the patient cells, telomere lengths, we can see that they're really short in comparison to healthy controls. So when we inject or transfect these mutations we found in patients into telomerase negative cells, we can see that telomerase activity, you just by what I'm saying here, but this is a trap assay that measures telomerase activity. This is a wild type, and this is telomerase activity from the mutants. And we can see that there is reduced telomerase activity from the cells in these patients, that these patients actually are heterozygotes for the mutations. And in the cells that were transfected, we see no telomerase activity, indicating that these mutations abrogate telomerase function or the capacity to elongate the telomeres in these cells, rendering eventually very short telomeres in peripheral blood, but also in hematopoietic stem cells in the bone marrow. This is an interesting family that had actually mutations in the RNA component of the telomerase, the molecule that serves as template to elongate telomeres. The proband came to us with aplastic anemia, but she also had two family members who were clinically healthy, but they also had carried the mutation, and they had very hypoplastic bone marrows, and also they had reduced number of CD34 cells. They had reduced colon information units in the CFU assays, and high levels of growth factors in the plasma, which was not found in the individual, in the brother who was not affected by the mutation. This has very important implications for transplant, since if you transplant this patient from a family sibling donor that also carry the mutation, you might have graft failure because you failed to get enough CD34 cells from the donor. So since we found about 10% of the patients with apparently acquired aplastic anemia had a very significant correlation with short telomeres and mutations in the telomerase components, similar to what we see in this Kurtosis congenita, We asked the question whether the other 90% of patients with aplastic anemia, is there any role of telomeres in the pathophysiology of these patients and the clinical outcome of these patients? So we looked at 183 patients with aplastic anemia that were treated with immunosuppressive therapy that was basically ATG plus cyclosporine at the NIH over 3 different protocols. And here we see the telomere length from healthy controls that is similar to the previous images that I showed you. And when we measured the telomere length before they received any therapy, or we just first came to our clinic, we saw that there was an overlap between the telomere length in healthy controls, age-matched healthy controls, and the patients. There were just a few individuals here that had very short telomeres, and there was just one individual, if I'm not mistaken, it's this individual here, who had a telomerase mutation that we didn't know about that when the patient come to us and he started in the protocol. But then we decided to divide the patients according to the quartiles. We divided them into 4 quartiles. Here are the patients according to age. The patients in the shortest quartiles for telomere length, and the patients with the longer telomere lengths in this quartile and these other 2 quartiles. And when we saw that, the response rate to immunosuppressive therapy was very similar in all 4 quartiles. However, the chances of relapse increased as the telomeres got shorter in the peripheral blood leukocytes of these patients, as we can see here in this graphic, as those with the longest telomeres had the least chance to relapse after immunosuppressive therapy and after they responded to immunosuppressive therapy. This is the multivariate analysis, also looking at telomere length as a continuous variable, and we also see that it sticks out as an important risk factor for clonal evolution and relapse. We also looked at clonal evolution in these individuals and the evolution to myelodysplasia with abnormal cytogenetics, as well as evolution to acute myeloid leukemia. And we found that in the patients in the shortest quartile for telomere length, the chances of evolving to MDS or AML was much higher, about 4 times higher in this group of patients, regardless of their age, than in patients with longer telomeres. The same thing happened to immunosomy 7, which is the most feared complication or cytogenetic abnormality found in aplastic anemia after immunosuppression, and it also much higher in patients with shorter telomeres in comparison to patients with longer telomeres. So the overall survival of patients in the shortest quartile was significantly lower in comparison to the patients in the longer quartiles. And if we combine together the telomere length that can predict the complications of immunosuppressive therapy, which are relapse and clonal evolution, along with the absolute reticulocyte count, which is a predictor of response to immunosuppressive therapy, we have pretty much 3 groups. Those individuals with long telomeres and with high reticulocyte count, and we can reassure these patients they're very likely to respond to immunosuppressive therapy and very likely to stay well after response is achieved, as we can see in this group here. As opposed to the patients with low retic counts as well as short telomeres, these patients have a lower chance to respond to immunosuppressive therapy, and they have a higher chance even if they respond to relapse or to evolve. And we can see that the overall survival for these patients is approximately half of the other group. And these patients might benefit then from hematopoietic stem cell, especially unrelated transplantation if they don't have a sibling donor. And we have the intermediate groups here, whether short telomeres or reticulocyte counts that had similar overall survival, that is intermediate between these 2 groups. So we have here 2 factors that are rather simple. The reticulocyte count, that is 20,000 above or below 20,000, that is a very simple test. And the telomere length, that is a little bit complicated test, but can be routinely done in most labs that are familiar with RT-PCR or qPCR. to predict response to immunosuppressive therapy in patients with aplastic anemia. But what exactly happens in the biology of these cells when the telomeres get short? And we saw in this group of patients that those who had shorter telomeres, the telomeres were unable to cap properly the ends of the chromosomes. As we can see here, telomere-free ends of from the chromosomes, as opposed to controls or the patients with longer telomeres, in which we can see 4 dots for each chromosome. And this means that the telomeres, they lose their major function, that is to cap the telomeres and protect end-to-end fusion or recombination of the chromosomes. We also saw at diagnosis a higher proportion of monosomy 7 cells and interphase cells, as shown here, in patients with shorter telomeres in comparison to patients with longer telomeres, indicating also that you have more aneuploidy in the bone marrow cells at diagnosis from patients with short telomeres. And we saw a bunch of chromosomal abnormalities that are not regularly seen, even Robertsonian translocations or insertions and even deletions that we saw using spectral karyotyping the bone marrows from these patients that were not observed in the patients with longer telomeres, indicating then that this short telomeres is causing chromosomal instability and evolution to hematopoietic cancer. Given these results, we also looked at whether constitutional telomerase mutations could be a risk factor for acute myeloid leukemia. And we found that we studied 3 cohorts, one from Brazil at the University of Sao Paolo, the other one from the MD Anderson, provided by Dr. Eli Asti, as well as a 3rd cohort from the University of British Columbia in Vancouver. And we found about 8% of patients with mutations in the telomerase, either in heterozygous or in homozygous state. And these mutations in the first cohort were mainly associated with version 16, complex deletion, and very interestingly, with acute promyelocytic leukemia in this cohort. We also confirmed the results in the MD Anderson cohort, and here the mutations were also associated with trisomy 8 in version 16, showing up here again. And we know also that in this kurtosis congenita, although it's a bone marrow failure syndrome, it has a very high chance to evolve to cancer, and here see the overall cumulative incidence of cancer as well as from MDS. The chances of evolving to AML in this kurtosis is about 200 times higher than in the general population. And the cancer, the rate of tongue squamous cell carcinoma is about 1,200 times higher in these patients than in the normal population. To wrap up, we also know from recent data that in GWAS studies that the telomerase locus is a very significant risk factor for a variety of cancers, not only lung cancer, but also bladder cancer, glioma. There is a variety of different adenocarcinomas that have been picked as that show that the telomerase locus in the chromosome 5 is a very significant risk factor for cancer. So we now understand that the telomere erosion causes this telomere-free ends, and in most of the cells in the bone marrow, it activates p53, p21, and the cell goes through senescence and apoptosis, and this might lead to bone marrow failure or aplastic anemia. However, in a minority of cells, you might have chromosomal instability because of the uncapped chromosomes, and this might lead to end-to-end fusions, aneuploidy, as well as chromosomal translocations or structural abnormalities in the chromosomes that eventually might lead to malignant transformation in aplastic anemia. We also see the relationship between telomeres and the risk of cancer as a spectrum in one site in which we have a more telomere loss and a higher risk of cancer at this site, which is this kurtosis congenita. We have a very high risk of developing AML and squamous cell carcinoma. And in the other end, the polymorphisms in the third locus, in which has an increased risk for a variety of cancer. In the middle, inflammatory diseases such as aplastic anemia, in which we have inflammation in the bone marrow, and also inflammatory bowel disease, Barrett's esophagitis, that he didn't have time to talk about, but he have intermediate telomere shortening as well as a higher risk of developing cancer. About treating these patients, I'll just go briefly about the use of androgens in these patients. We know for a very long time, and a good deal of physicians here do use androgens to treat moderate aplastic anemia. This is one of our patients who we found who had a telomerase mutation. And 20 years before we identified the mutation, she was treated with androgens, with decadrabolin, with very good response in her hematocrit, but also in the other two cell lines. And we know since the work from Sanchez-Medel in Mexico that the androgens may be helpful in aplastic anemia. But we found that when we culture lymphocytes or CD34 cells from whether healthy controls or patients with mutations, we saw that androgens were able to increase telomerase activity in these cells. But also estradiol was also able to increase telomerase activity. In conclusion, I would like to say that just to wrap up, and to see the clinical importance of what I mentioned here, is that the investigation of telomerase mutations may be important, especially for patients who have a sibling donor, to make sure that the donor does not a silent carrier of a mutation. And mutation screening may be helpful in these cases. As well as for the therapy, androgens may be helpful in the treatment of dyskurtosis. About 60% of patients do respond. And a variety of patients with aplastic anemia do respond to androgens, and especially patients with mutations, about 60% of them do respond to the therapy. I'd like to thank my colleagues, especially my previous mentor, Dr. New Young, who is the chief of the hematology branch, and the students who did the work there, as well as my new lab at the University of Sao Paolo, and the collaborators all over the world who helped me to do this work. Thank you very much.
So which centers routinely do telomerase evaluation before treating aplastic anemia?
Well, I do that at University of Sao Paulo. The NIH does that regularly. There is a commercial company in Vancouver, in Canada, who does that routinely for patients over in the United States, as well as in Switzerland. There is a company that also does that commercially. These are the ones that I know of right now.
And in terms of transplant donors, it may be that we're just ignorant that we haven't recognized this, but it's unusual to find a family member of an aplastic anemia patient when you're not looking at not specifically looking for telomerase that has has a hematologic problem and then functions poorly as a donor. So I'm wondering if somehow by selection of the patients that you've been referred, you might have a higher incidence of this mutation than the general population.
That's likely the case. However, it's interesting that about 5 to 10% of cases with aplastic anemia that were transplanted, they do have graft failure, and we don't know whether these graft failures after transplant, that is a very common number, about 5 to 10%, if they did have mutations.
Okay. Right. I think. Right, a quick one.
One quick one. Rodrigo, what is known about the effects of chemotherapy on telomere length, and whether that predicts for MDS, and are there any specific agents that have a more profound effect on the telomere?
Yeah, that's a very good question. Actually, there is very little evidence about it, about this iatrogenic telomere shortening caused by chemotherapy. We know from autologous hematopoietic stem cell transplant that you can get shorter telomeres. And there is a work, it's from the US, I forgot where it's from, but they show that individuals who received autologous transplant and had a higher rate of telomere shortening after transplant were at higher risk of MDS. With Guillermo Garcia Manedo at the MD Anderson, we studied about 200 individuals to 100 individuals who had secondary MDS and 100 patients who were treated with the same chemotherapy and never developed any secondary malignancy or no secondary malignancy or MDS over 10 years. And we found that In the group who developed MDS, they had shorter telomeres. They were treated either for breast cancer or for lymphoma. And those who eventually developed MDS after a period of 10 years, they had shorter telomeres than those who did not develop a secondary MDS.
Thank you.